So happy to welcome you to the fourth annual Palliative Care Institute conference. The Palliative Care Institute's mission is to transform palliative care in Whatcom County and support our human responses to living and dying. And we seek to create a healing community by fostering support so that people living with serious illness or facing the end of life don't have to be cured to heal. And we build on collaborations among those both inside and outside of the medical industry. Reclaiming palliative care is our shared community responsibility. The Institute is housed in the Woodring College of Education at Western Washington University, and we are grateful to both the university and to the college for their ongoing support for our work. And I would like to invite Dean Francisco Rios, who's Dean of Woodring College, to help welcome you to our shared work together today.
Muy buenos dias. Good morning. It's great to see you all here. Well, you look fabulous. You look beautiful. And we're so glad that you're here. I really appreciate this opportunity to welcome you all as well on behalf of both the college and the university. And we are very honored to serve as the home of the Palliative Care Institute in the College of Education, and can't tell you how thrilled we are by the quality of work that the Palliative Care Institute is doing really on behalf of the community. I really, in particular, am really impressed and grateful that we're able to share and leverage the university's resources and expertise to help educate and inform, to help connect you all together and bring resources and networks together of people. And to be able to really address critical community needs. And that's what we're about in the College of Education. I would also suggest that that's what we're about at the university. I want to offer my special appreciation to Marie and Sarah and all the team, the advisory members of the palliative care who worked so hard to put this on. Carola, who's out at one of the tables out there. Oh, there she is over there, Carola. This work, let's give them all a hand, yeah. As you know, all these events take lots of energy and effort and great vision, and that's a team of people who I think we're lucky enough to be working with in the university and in the college. With that, I want to wish you all the most wonderful event, and that you find it both positive and productive, and amazed to think about this as the fourth annual. Best wishes to you all.
So I'm going to share Francisco's thank you initiative. And I want to say a special thanks to Dean Rios himself for being a great advocate for us at the university and for the university and the College of Education's belief in the power of collaborative community work. I also have to say, again, to my team, to Sarah Weir and to Aurora Fox, who's back at the empathy card table, and to Katie Harrison out there at the desk, and to Carola Williams, who's handling all the CME work. Francisco is absolutely right. It takes a lot of folks to put something like this together. And also a special thanks to our donors. So we got a lovely grant from Paul Razor at Sanitary Service Company. And then we also got a number of donations through our Viking Funder initiative that have provided scholarships for 10 people today. So I'm thrilled that some folks who might not otherwise be able to come were able to come. And a very special thanks to a man named Craig Abramson, who is not here, but he called me a month ago and he told me about a book he had published. And it's a beautiful volume of paintings and poems by Lynn Sad, a Seattle artist. And it documents her journey during the last 18 months of her life as she negotiated aggressive breast cancer. He offered to give me some copies. And I said, oh, I would love to have a couple of copies that I could give to the speakers as a special thank you. He said, oh no, I'll give you enough for everyone at the conference. So they're on a pile over there at that table. And if you would like to take one home, please do. So only one copy per person, please. But there are enough for everyone, so you don't have to rush over there. But as you before you leave today, I encourage you to go look at it, and if you would like to have it, you're welcome to take one. If you'd rather not have it, then leave it for someone else, because there will be other people to give it to. For those of you who came in late, I want to remind you how to get on Wi-Fi. The BTC hotspot is called BTC, all lowercase. And the password is gateway, all lowercase. I also need to tell you where the bathrooms are. So go out the door, turn right, and they're on your left-hand side. The final little bit of housekeeping is that when we are in the afternoon and moving to breakout sessions, one of the sessions will be in here and the other two will be in classrooms that are just behind that wall, the back wall behind the coffee. And I also want to invite you at any time when you just feel like if your hands get kind of antsy and maybe you're a person who listens better when you're doing something, go back and join Aurora and make yourself an empathy card. It's one of the things that happen out of an initiative that from a conference just like this, when someone said, I have a great idea. We ought to have cards that you could actually give to people when they get diagnosed with cancer, because get well soon just doesn't cut it. So there's an opportunity for you to make a card for someone that you think needs a different kind of message than you can typically find. So the past 4 years have offered us opportunities to gather and explore various aspects of serious illness and end of life. And you'll see on the wall a couple of the posters from previous conferences that if you were here, you can track some of the things that happened. And I'm hoping that they will be enlightening to you. But we had conversations about healthcare reform and about how practitioners and patients can have better conversations about choices when serious illness presents. We've talked about the role of complementary care in pain management and other serious illness and end-of-life challenges. We've talked about changing the cultural taboos around talking about death and dying. And last year's conference introduced the theme of care for the caregiver, encompassing both family caregivers and those practitioners who care for seriously ill and dying patients as their work and their calling. The overwhelming feedback from last year's conference was that we should continue that conversation at this year's event, and that's why we're here today. So this morning, our two keynote speakers, Casey Shillam and Simon Fox, will help focus our attention on the challenges of caregiving and ways to build resilience. An additional focus of the Palliative Care Institute's work this year has been to help create a more culturally responsive caregiving in both formal and informal settings. And so this afternoon, Sandra Hernandez will lead us and guide us through ways to integrate cultural beliefs and attitudes about serious illness and end-of-life care into our work in both our clinic and community settings. And then finally, in the late afternoon, you'll have the hard choice of attending one of the breakout sessions. And then finally, Sarah Weir is going to lead us with some collaborative looking ahead and agenda setting to guide our work together. So we have a big day together. And I hope you help yourself to a little breakfast and coffee and that you're ready to enjoy our time together. So I'm thrilled to introduce the first speaker. And this is welcoming Casey Shillam back home. Casey is currently the Associate Dean for the undergraduate program at the University of Portland School of Nursing, and she is a Robert Wood Johnson Foundation Executive Nurse Fellow. And I won't repeat all the information that's in the short bio in your program, but in addition to all the accolades there, I want you to know that Casey was the founding director of the RN to BSN nursing program in Woodring College of Education. And she also launched the Palliative Care Initiative, which sponsored our early conferences and eventually became the Palliative Care Institute. So Casey, thank you for your vision and your groundbreaking work in this field. So please welcome Casey Shillam.
Thank you, Marie. Good morning, everyone. It is so fantastic to be back in Bellingham, and just to say thank you for welcoming me back again this year. I had planned on attending last year. I was all scheduled to come, and then I had a real life experience of understanding what does palliative care mean, how do you make tough choices, and what does this mean in my own life. A couple of weeks before I was supposed to come for last year's event, my father was in a very serious motorcycle accident. And it was terrifying because I was in that moment of, okay, I've spent my life teaching others how to do this, and now I don't have a clue about what I'm doing. So knowing that it was okay for me to tell Marie that I couldn't be here last year because I knew that this group would understand was very comforting to me. So I just want to say thank you. And now I know why I had to wait a year to come, because I have learned even more about what it means to be a caregiver, to care for my own family, my father, to be in those intimate moments when he was recovering. So the good news is he has fully recovered from 5 fractured vertebrae, broken ribs, and he is walking and healthy and happy, and he has moved closer to us, and it's brought our family even closer. So I just wanted to report out that he is healthy and well, and our family is so grateful. But now I can share an even different perspective with all of you. So I'm very happy to be here. And I've been doing some work in the world of understanding what does anti-fragile mean versus resilience. And it's kind of a scary place to be, because I was sharing with Simon, he and I had a phone call, and I was a little nervous about talking about this concept because it's not something that's very well known in palliative care, much less in healthcare, the healthcare arena. Um, but Nassim Taleb has introduced this concept of anti-fragile in the organizational world, talking about what it means to become stronger. And so as I've started to do work in my own organization around becoming anti-fragile, then I had this experience with my father last year. It helped me to see that this is a natural pathway for us to be considering how do we take care of ourselves as caregivers and move beyond resilience, in essence, to become anti-fragile ourselves in this work. So that's just setting a little bit of context and framework for what I'm going to be talking about this morning, and then setting the stage for us to develop some of those skills together today. One of the ways that I do things purposefully to make sure that I am taking care of myself. So I'm giving away a secret right now. Okay, secret, take note. How do you take care of yourself? I purposefully embed things into my presentations that give me peace, that calm me down, that keep me centered and focused. So when selecting the background for the presentation that I wanted to offer today, I chose something that brings me peace. So knowing that water is what centers and grounds me, whether I am at the beach or whether I'm on a boat in the San Juan Islands, water is my grounding source. And so think about how in your everyday work you can start embedding those pieces that others can enjoy and appreciate, but that help keep you grounded and centered. So I just wanted to point that out, that was a purposeful choice on my part for me to be able to continue to be present and grounded. Of course, we're offering CMEs, so I'm doing the obligatory, these are the objectives of our time together. You guys can read these on your own, but really what we're going to talk about this morning is understanding what contributes to compassion fatigue. How does it show up in caregivers, whether we're talking professional, licensed caregivers in the healthcare arena, if we're talking about family caregivers or caregivers of friends or community members, what does that look like and what is the impact? And then talking about what does it mean to move beyond that resilience concept to thinking of this work and how to care for ourselves in a way that is anti-fragile. And then in my breakout session, sorry, shameless plug, why you want to choose me over the other two? Where I am going to talk about how to actually apply this into work, whether it's your professional life or whether you're a family caregiver. So that's where I'll be heading in this afternoon. In order to have this conversation, it's important that we all have a common shared understanding of the concepts that I'm talking about. And so I just wanted to run through some of these definitions to provide some context for what this means for us. Compassion fatigue is made up of multiple concepts and different things. The founding reason why we are caregivers, why we do what we do as a caregiver, is because of this concept of caregiver satisfaction, compassion satisfaction. I didn't become a nurse because I didn't really want to take care of people. You don't go into healthcare or caring for people because, yeah, I guess I can do it. Nobody survives doing that. There is an inherent satisfaction and joy in what we do and why we do it. So again, I chose this picture for a reason, because in my master's program, I was at the Oregon Health and Science University Pain Management Clinic, and I was conducting a study to understand if older adults had the capacity to enter their pain information into an electronic database that was reliable and valid. So that tells you this was a while ago, because yes, we know older adults can use technology. But in that world, we didn't know. We were just creating these databases to see if we could start tracking the aggregate information for all of our population of chronic pain patients. And so I'm in this work, and I'm doing this, and I'm having so much fun. And I'm like, yes, I've got it all figured out, and I can instruct the older adults on how to enter the information, and they're entering their data. And I'm seeing that they're entering their pain scores of, that 0 to 10 pain scale. They're putting in a 3 or a 4. And the distress scale, 0 to 10, how distressing is your pain? And they're including, maybe a 1, maybe a 2. And then as I'm seeing them enter those numbers while they're sitting in the waiting room, I made these really powerful observations when I saw them pushing themselves up out of the seat in the waiting room and hobbling down the hall to the exam room, having to depend on somebody to hold them up or using some kind of an assistive device. And I'm like, I don't think those are reliable and valid numbers. That doesn't look like a pain level of 4. What's happening there? And that observation, that moment of looking and understanding that the number doesn't reflect a person's experience, is what led me to thinking about how does this happen? And it led me to understanding about resilience and about how our own internal perceptions of our conditions make our own reality and help us to be able to deal with them and to manage with them in very different ways than being an observer saying, oh, well, you say your pain is a 3. You obviously don't need any pain management. So this picture comes from the poster presentation at my very first research conference, where I presented my master's thesis work. And I used this picture because it was so far beyond the numbers. And it is what led me down this path of wanting to work with people across the trajectory of their serious illness and in managing their pain. So that's where I started to notice that there's something more than just the number. And it is that satisfaction piece. It's the satisfaction that we have in working with people who are very vulnerable, who are seriously ill, but it still brings joy into our lives. And it can be in these small moments where we have a moment with someone we were able to enjoy in the everyday living, or we're able to help manage their pain so that they can continue to live independently, or they can continue to work in a garden, or they continue to be with their grandkids. Those are the pieces of the satisfaction that we get from working in compassion. Now, the challenge and the danger is when it goes beyond that compassion satisfaction. So what we know happens, and we have plenty of literature, data, and research to support this, is that when we're in those moments, they're not all beautiful and rosy and happy and fulfilling. Sometimes it's really hard. And it is painful to watch someone that you know, or that you love, or that you care about, or that you care for in that professional capacity be in that much pain or endure that much suffering. And so what we see happens is there's this transition from the satisfaction component to this compassion fatigue component. And that's where we're continuously inundated with that tension and that stress. And when we start to cross the threshold of no longer being able to rebound and see that satisfaction piece, but we almost start to become indifferent, or we see that there's this kind of avoidance and not wanting to acknowledge that this person's suffering is starting to affect us. So what happens is that we are caring for another in such a way that it winds up actually making us become fatigued. And it starts to have a negative impact on us as caregivers. And then if that tension continues and we don't acknowledge it, we don't recognize it in ourselves, then we start to become unraveled. We start to lose our way to be able to actually manage that tension, and it starts to consume us. That can then lead to secondary trauma stress. So think of this as a continuum, really, and we fluctuate back and forth among all of these different states. And this secondary trauma stress is then when we're starting to get to that danger zone, where we're not recognizing the impact it's having on us, and then we start to exhibit signs actually of post-traumatic stress disorder. Again, if we recognize it in ourselves and we're able to develop those strategies to deal with it in a healthy way, acknowledging that it's going to happen, but we know how to pull ourselves back, then we can fluctuate back towards that place of having satisfaction. If we don't recognize it, this is where the ultimate danger zone happens, and we lose our ability to really get back to that place of satisfaction. We lose our ability to understand that this is a part of our role as a caregiver, whether it's in a medical profession, a healthcare profession, a nursing profession, or as a family caregiver. And underneath that chronic level of stress, we are no longer able to find that satisfaction component. And that is when we develop that emotional exhaustion, that cynicism, and that inability to have personal efficacy. So just to give a couple of pieces of data in terms of the context of how prevalent this is and what does this mean for our healthcare professionals, one study found that 8 out of 10 nurses accessed their employee assistance programs in their organizations. And that is double the number of general EAP access from any organization. So national levels, nurses twice as high. In oncology physicians, we find that up to 50% report that emotional exhaustion piece, that piece up there that contributes so much to burnout. So in order to then see the impact this can have in the community or in homes or in families or in hospitals, we do see that we have higher levels of falls with injury in inpatient settings, in post-acute care, in assisted living facilities, when we have higher levels of burnout in our care providers. We also see that there's a relationship between hospital-acquired infections, urinary tract infections, and higher levels of burnout and compassion fatigue in healthcare providers. Whether we're in communities or in assisted living or long-term care, we also see there are correlations between higher levels of compassion fatigue and burnout and increased mortality and medication errors. Then looking at all of the impact on the care providers, we also see these signs that do reflect that post-traumatic stress disorder. We see that there's an increase in exhaustion, in anger, in higher uses of substance abuse and use. And the piece that I want to focus on here for just a moment is that piece of not being able to distinguish between the professional world and your personal world. So as an associate dean for a school of nursing, I am now responsible for 800 undergraduate students in the School of Nursing. And let me tell you, when the stress is high at work, and I'm working with some very vulnerable times in students' lives, and many of the skills I've developed as a nurse translate very well into caring for nursing students, let me tell you. And as I started to think about my role as being an associate dean and providing care and support for nursing students, I see the same thing in this role that I do as a nurse, and that is that we are there in times of great joy and great celebration. Becoming a nurse, getting into nursing school, graduating from nursing school. Those are wonderful joys, seeing the connections nursing students make with having that connection with a patient, or finding that, oh, I didn't really want to work in an acute care, I don't want to be a medical surgical nurse. I want to be a hospice nurse. Oh, the joy I feel in my heart when I have those connections and those times with students is great. And on the flip side, the sadness that I experience with students is very real and is very intense emotionally for me because I am there when the student isn't successful. I'm the one who has to help that student guide into another profession, another major. I'm there when there are mental health crises for students. And so those really challenging times in a student's life, I'm there in the beginning and I'm there in the end and I'm there all the way through. And I've reflected back to my nursing practice, and that is what we do as care providers. We are there in great moments of joy and in great moments of stress and tension. But when we're not able to find that centered source of, okay, there has to be some place or space where I can care for myself, it consumes us. With this being my professional job, I can distinguish that. I can know that, yes, I'm having high levels of tension. I'm starting to feel compassion fatigue. I'm trying to avoid the secondary trauma stress, but I can recognize that. But let me tell you what, last summer, when I was in the intensive care unit caring for my father, I could not distinguish those two. I could not tease those apart. I couldn't separate those out. So knowing that there again is a continuum that we will face on that ability to separate the compassion satisfaction that we get and the compassion fatigue we can experience, we have to be able to acknowledge when that's happening so we know when to pull ourselves out and to just be aware that it's going to be so challenging when we are in those moments of being the caregiver to a family member is what's going to lead you to being able to be successful. So here are those components that all lead to burnout. And what we see is through this model is we know all three of these concepts exist when we are a caregiver. We have compassion satisfaction. That's the place where we find our most joy and our ability to be successful in what we do, whether it is, again, as a profession or